So, welcome to AETCM, the Emergency Medicine channel. Today, we'll be discussing a case of an elderly patient who presented to us with respiratory distress.
Okay.
So, there was a 72-year-old female patient who came in with a history of fever with productive cough on and off since about a week. She was treated on an outpatient basis, but because she had worsening breathing difficulty, following which she had respiratory distress, is why she was brought to our hospital.
Okay.
For further management. So in our initial 10-second assessment, patient was seemed to be in respiratory acidosis, conscious, but she wasn't well oriented to time place because she was very breathless. She couldn't talk in one full complete sentence.
Okay.
So in our primary survey, airway appeared patent for now as she was able to talk, but just not in complete sentence. But there was no anatomical deformities as such. No increased secretions, no stridor noted, no hoarseness of voice also noted.
Okay.
So moving on to breathing, she had a respiratory rate of about 43 cycles per minute with a saturation of only about 81 to 82% in room air. Plus she was tachypneic and air entry was bilaterally equal, although there wasn't enough chest excursion as she was breathing too fast and usage of accessory muscles, basically in respiratory distress. And bilaterally on quick auscultation, we found out that the patient also has crepitations, but mostly inspiratory crepitations, predominantly on the right side.
Okay.
But it was there all over the lung fields, but more commonly in the right subclavicular and basal area. Then with wheeze. So this was our breathing, but there was no distended neck veins noted and trachea was central in position.
Okay.
So circulation-wise, she was tachycardic with a heart rate of 122 beats per minute. Blood pressure was 100 over 60 millimeter mercury. All peripheral pulses were palpable and warm. So then rhythm was regular in nature. And moving on to the disability-wise, she had a full score, but she was agitated, restless, and in distress. And pupils, however, were bilaterally equally and symmetrically reactive to light. Then exposure-wise, she was running a temperature of 100.8 degree Fahrenheit with the blood sugar levels of 487 milligram per deciliter.
Okay.
So from here, what we have found out is that the patient was in respiratory distress with uncontrolled blood sugar levels, and she was febrile.
Okay.
So simultaneously, as and when we found out that the patient has breathing difficulty and tachycardic and fever, interventions were done parallelly.
Okay.
So for airway, we kept her in a propped up, comfortable position, and then the breathing wise, we gave her a NRBM. With high flow oxygen, while we were also planning for a positive pressure ventilation, like a BiPAP, if the patient deteriorates.
Okay.
And then,
so if you have a BiPAP machine or NIV in your emergency room, it's always better to go for NIV in most of the respiratory condition. But to buy time, we always start NRBM. And get the machine and start. Okay.
So then, for circulation bit, we inserted 2 large bore IV cannulas. And we started the patient on 30 ml per kg IV fluids because BP was also on a lower end of normal, like 100 over 60.
Okay.
And so considering how she was febrile, we were suspecting sepsis. So initiated fluid resuscitation at the earliest. Along with this, we gave an antipyretic, that is paracetamol, 1 gram IV was given start. So then simultaneously, we collected the blood for routine lab investigations, including blood culture. And moving on to the adjuncts of primary survey, we took an ABG.
What is the importance of blood culture? How many patients you get positivity? What is aerobic, anaerobic, all these things?
Mostly we get, even if the patient has bacteria in the blood, but only about 20 to 30% only will show.
So percentage of yield from a patient who is having infection is only up to 30% maximum, most of the infections. So that number of patients who are turning positive will be very less. Second thing is normally in guide, according to standard guidelines, we need to send 2 sets of 2 samples. So that means one aerobic, one anaerobic, that is one set. Another set is one aerobic and another anaerobic test. Is it all required or
from two different sites? So that
two
was
different
to
sites.
reduce the possibility of contamination.
Skin contamination.
Skin
So is it all
contamination.
required in a country like India?
Yes.
Huh? Financial issues are very important because if you are taking 4 samples, that in a normal hospital itself it costs around 4,000 rupees, and your yield is only 30%. Okay, maximum is 30%. And clinically, if you are able to make a diagnosis of what is the reason for infection, then that is more than enough. 1 or 2 samples you can send, but 4 or 5 samples for just for a routine patient in our country will be very difficult. And moreover, that anaerobic infection in a routine septic case, anaerobic infection most of the time it will be negative, and very rarely you get a positive case. Okay, but most of the antibiotics what you use in sepsis will cover anaerobes. So that also can be avoided, but according to standard guidelines like sepsis bundle and all, we have to start it. Okay, IDSA guideline, so you have to start it. Sorry, you have to take the culture. Okay.
So then in our adjuncts, we took an arterial blood gas as she also had a respiratory component and what. And we found that the patient had respiratory alkalosis with a pH of 7.47 with and a bicarbonate of 30.2. Not bicarbonate, PCO2 of 30.2 and bicarbonate was 20.1.
Okay.
Now, along with this, PO2, however, was only 53.7 and an SO2 of 82.
Okay.
And lactate was slightly on a higher level of 2.7. 2.5 would be the cutoff. This patient had only 2.7. So these were the parameters that we picked up from arterial blood gas. And then we initiated the patient, we had already initiated the patient on an RBM.
What is the potassium level in this patient?
4.2.
Okay. Is it important for managing this patient?
For respiratory alkalosis of
this patient is having hyperglycemia. So anyway, you will be starting this patient on insulin. So we should know what is the potassium level. Without knowing that, if we start insulin patient, they may develop shift hypokalemia.
Then apart from this, we took an ECG and we found that the patient only had sinus tachycardia. There was no evidence of any STT changes or afibrillation or any of the other arrhythmias noted. Then apart from that, we did a bedside ultrasound and we saw that the patient had lung sliding present bilaterally. That ruled out the possibility of pneumothorax, but she had little effusion on the right side, but very minimal. What we noticed was that the patient also had a starry sky, like a tissue-like consolidation on the right side. So we knew that we were looking at a consolidatory patch, probably on the right side, probably on the upper lobe. So with this basic idea, we moved on to the sample history.
Normally, this patient you have only right-sided pneumonia, but on auscultation you are getting bilateral extensive crepitation. How do you justify that? What may be the reason for that?
Possibly that it is still on the right side. There's a formed consolidation. So
that's okay.
Maybe in a while in the left side also it will form. Probably it's still in the forming phase.
Either you can think this patient is having a spillover infection on the opposite side. There is one possibility. Normally, when you are managing pneumonia case in your emergency room, most of the time secretions are very high. A lot of secretions will be there in the throat. That is producing crepitations. So that producing that crepitation sound, but it is produced here in the throat. So when you are auscultating, you get that sound in that area. But if you ask the patient to clear the throat by coughing or you aspirate and see or put the patient on one side, lateral position, all these things may disappear because most of the time these patients will have a lot of secretion clogging inside the trachea. That has to be removed.
So then moving on to the sample history, she was known case of diabetes, coronary artery disease, systemic hypertension, chronic kidney disease and hypothyroidism. These are the 5 comorbidities that she was suffering from, and she also has had past history of BPPV and Mallory waist tear was there in 2019. So we also have to here consider the possibility of a pneumomediastinum also for sudden breathing difficulty, and crepitations could possibly be even the Haman's sign also. So but then when we did the ultrasound, we didn't really find any subcutaneous emphysema or any other features that were suggestive. Moving on to her medication history, she was on dual antiplatelets. with the ecosprin and clopolid, both of 75 milligram, and she was also on rosuvastatin 10 mg. Then she was on bisoprolol beta blocker 5 mg that she used to take one dose in the morning, clinidipine 10 mg that she used to take twice daily, along with this thyronorm 50 microgram one daily dose, and OHAs glimepiride, teneligliptin, glycomet. These were the 3 OHAs that she was on, in addition to human mixture and Lantus. So these were her medications. Allergy history, she didn't seem to have any, and last meal wasn't really known.
Okay.
Then, so the event, it just so happened that the patient was having a high-grade fever along with on and off intermittent non-radiating pleuritic chest pain, along with productive cough. But initially, the breathing difficulty wasn't as much, so she was just being treated on an OPD basis. So then, insidious onset, progressively worsening breathing difficulty happened along with increased fatigue, to an extent that she wasn't able to do her routine activities. So MMRC grade 3 to 4 is how she progressed.
Okay.
And when her symptoms persisted and wasn't getting resolved through the OPD medications, is why she turned up to the hospital. So she did not have any history of hemoptysis, no past history of TB, no recent hospitalizations, no vomiting noted, altered sensorium she didn't have, and she was able to eat well, no any signs and symptoms that were suggestive of aspiration at this point. Then dyspnea and exertion was there, chest pain, but not accompanied with any syncope or palpitations or any of that sort. Then bowel bladder issues she didn't have, no rashes also noted anywhere. So with this, although she also had dysuria and increased appetite with increased thirst, these were also her symptoms. So with this now, so far what we have is a sepsis patient who is now in an impending shock state. So that's one entity that we have to treat. And the second is the uncontrolled sugars. So now we have the X-ray also confirmed our right upper lobe patch with bilateral heterogeneous infiltrates, but predominantly on the right side. And urine routine was suggestive of UTI. She had a procal of 3.2 with a total counts of 23,000, and the CRP was 233. So raised inflammatory markers, a sepsis, impending shock, along with uncontrolled blood sugars. So these were the major entities that we had to treat. So according to the surviving sepsis campaign, we started the patient on IV fluids, like I mentioned, 30 ml per kg, and a quick bedside echo showed good LV. So we could give fluids. There was no signs of any pulmonary edema or fluid overload state, and IVC was also collapsible. So with this, we catheterized the patient, monitored her urine output. Our target was to reach 0.5 to 1 ml per kg per hour. Then repeat, after fluid resuscitation, repeat BP picked up to 126/70. So she was fluid responsive. Now the idea was to achieve a MAP of 65 mmHg. Then for blood sugar levels, we started her on a short-acting insulin, that is human actropid. We started the dose of 0.1 international unit per kg per hour. So then we titrated, checked the sugar levels
every 1 hour. So actually no need to give any bolus dose. You give infusion protocol, that is more than sufficient. Some book says you can give bolus and continue infusion. Some book says you give only infusion. Both are equally effective. That's why it is not required to give a bolus. But if you are giving bolus, that's also okay.
So 80 to 180 milligram per deciliter was our glycemic target. And then saturation, even with NRBM, she was able to pick up the saturation to about 95%. But she had increased work of breathing. So in view of respiratory distress, we put her on a BiPAP. So we started it with inspiratory pressure of
in a consolidation. Here the patient is having consolidation. How do it help the patient to improve the saturation?
So
if in pulmonary edema, it opens the alveoli, which is filled with water. Here, how do it improve?
So, sir, if the patient has an increased work of breathing, the consolidatory patches will have that debris, the mucus. So the bronchioles, the other bronchioles can open up, and then it can decrease the patient's work of breathing.
So they are called as dead spaces. Anatomically, there are a lot of dead spaces in our body, and many alveoli are collapsed. They are not used in the routine normal breathing. When you are starting BiPAP like this, consolidated area anyway, it cannot enter the air. It is consolidated. Other areas, alveoli will try to open it up, and dead spaces will be utilized. That improves the oxygenation. Okay, so BiPAP or NIV is very useful even in pneumonia.
So we started her on that in view of increased work of breathing, and after that, 2 hours later, a repeat ABG showed resolved lactate, and then ABG had no acid-base abnormality. Now
lactate can be elevated due to hypotension or hypoxemia, both.
Both. So, but in this, probably it was more
hypoxemic.
So her AVG improved. There was no acid-base derangement. Lactate levels settled down. And then we started, within first hour of her arrival to the emergency department itself, we started her on broad spectrum IV antibiotics. Okay. Here, even a respiratory.
What are the indicators which tell you that patient is failing on BiPAP?
Okay, a patient will have change in the mental status. Will have either the patient will become drowsy, or will become more agitated. Okay. Will fight the BiPAP, or patients, despite being on BiPAP, his PCO2 buildup will be there, and PO2 drop will be there. So there will be worsening in the ABG. Patient will have persistent tachycardia, and hemodynamic instability.
Actually, you have to monitor the HACOR score. That you have to monitor and document. As a postgraduate, you have to do that. But by clinical experience, you know that patient is not improving, his sensorium is not improving, hypoxemia is not getting corrected, pH is not getting corrected. All these things are there in the HACOR score, but you have to document that according to our HACOR score, this patient requires chance of going to mechanical ventilation. We have to predict.
So for IV antibiotics, a respiratory fluoroquinolone will do, but before that, we'll have to ask the patient for any past history of seizures and hypersensitivity reactions. Since this patient will not have any, we can just start the patient on a respiratory fluoroquinolone.
Which one you want?
Or levofloxacin.
Levofloxacin and moxifloxacin both are available. Levofloxacin can be started because it's available everywhere.
Or we can start with the combination of azithromycin, which is an it covers the atypical bacteria too.
But here the patient is having urinary tract infection, hyperglycemia, pneumonia. Okay. So one is levofloxacin you are starting means it will cover the pneumonia part and urinary tract infection. But what are the other possibilities? Normally we should have one differential diagnosis. What will be the differential diagnosis? You are happy with the only single diagnosis? Somebody, suppose it started with urinary tract infection, and secondary to urinary tract infection, sugar has increased, hyperglycemia, dehydration occurred. What will happen to the lung in that situation? Somebody is having illness, hyperglycemia, dehydration. What other thing can produce a shadow in the lung like this? Pulmonary embolism. See, pulmonary embolism can occur in this patient because this patient is having dehydration because of hyperglycemia. This patient is in sepsis. It can produce, it's another cause for the emboli. Okay, septic emboli, or it can produce acquired APLA syndrome. So many differential diagnoses you can think. If you don't think, ultimately you will go only in one track. You think that it is a sepsis, both pneumonia. One is pneumonia, one is urinary tract infection. But always you should have a differential diagnosis. Once in a while, you can get a patient who is having urinary tract infection, hyperglycemia, dehydration, pulmonary embolism. If you don't think in that way, you will definitely miss more dangerous pulmonary embolism here. Okay. In a routine way, you can think that there is a pneumonia, there is a urinary tract infection, the hyperglycemia, that's all. But if you are thinking more like a postgraduate, severe dehydration caused by your hyperglycemic state, secondary to urinary tract infection, now she is in a procoagulable state. That can produce pulmonary embolism. Okay. So in that way also you can think. You have to think in multiple ways. Okay.
So apart from this, the other antibiotics would be like a third generation cephalosporins can be given. Preferably azithromycin was used because it also has an anti-inflammatory action on the lungs. But other than that, piperacillin and tazobactam can be used. And if the patient deteriorates or if the patient does not progress well, then carbapenems can be thought of in terms of any MDR organisms.
Normally, if you are thinking about pneumonia in this patient, community acquired pneumonia, this patient has never gone to another hospital. He developed a pneumonia from home. Okay, so it's a community acquired pneumonia. She's only other problem is she's diabetic. Community acquired pneumonia means it is mostly gram positive. Okay. So what you told is levofloxacin is more than sufficient. But if the patient is having urinary tract infection, sepsis, septic pocket, which is producing pulmonary infiltrates, then it can be gram negative. Okay, it can be E. coli, Pseudomonas, or other type of bacteria because he's a chronic diabetic patient. In that sense, you can go for a higher antibiotic like Penicillin, Tazobactam, Ticarcillin, Clavulanate, Mirapanam, whatever, depending on your routine practice. Like some hospitals, you get more Pseudomonas. Some hospitals, because that all depends on your referral centers from where the patient is coming. Some hospital usually have bacterioflora like Pseudomonas, multi-drug resistant Pseudomonas are very common in some hospitals. Some hospital it may be Klebsiella. So we should know the bacterial flora of other hospitals also from where we are getting referrals. Then it will be easy to start the antibiotic. Okay, but here in India, unfortunately, these things are not documented. We have to take our own decision in emergency room. Like you told, we can start piperacillin and that covers most of the organisms, including Pseudomonas. Okay.
So that would be the antibiotic coverage. Then, since we know that this patient will not be immobilized for a while, we also have to start the patient on a DVT prophylaxis. In addition, because she's high risk for thrombi, like we discussed earlier. So, for pharmaceutical, we can start on a low molecular weight heparin. This patient did not have.
Creatinine is high, no?
1.89.
So you have to calculate the creatinine clearance and then only you should start low molecular weight heparin. If the creatinine clearance is low, you have to either you have to reduce the dose of low molecular weight heparin, otherwise you better go for unfractionated heparin. Okay.
So we started her on unfractionated heparin, 5,000 international units. We started on BD. But in addition to this, she also had elevated cardiac enzymes, even though there was no STT significant changes in ECG, and her consistently it was on the raising end. So we started her also on heparin itself, but we gave it as a therapeutic dose.
So what may be the reason for elevation in the cardiac enzymes here?
Sepsis itself.
It's sepsis because the blood contains toxins. Hypoxemia is there. Cardiac muscles are not getting the normal blood. It is getting blood supply is there, but the effective circulation is less oxygen or more toxin to the myocardium. That produces myocarditis and elevation in the cardiac enzyme. So most of the sepsis patients, if you see, the cardiac enzymes will be elevated, and you have a renal failure also here. That also increases the CKMB, troponin T slightly. Okay, so it is not acute myocardial syndrome. It is only a part of the sepsis. So no need to raise the insulin dose to like a patient what you are giving in myocardial infarction.
So then within 12 hours, her...
what is the age of the patient?
72.
72.
So within 12 hours of her admission to the critical care unit, her blood culture turned positive for GNB.
Okay.
So sensitivity report is yet to come. Then depending on the sensitivity report, we'll have to modify our antibiotic regimen.
Okay.
So repeat assessment, she became hemodynamically stable as she was also fluid responsive. And then her respiratory work of breathing also improved. Then apart from this, the other thing that we'll have to talk about is the nutrition of the patient and how much fluid the patient should be receiving. The input-output charting should show a positive balance of 500 to 1000 ml.
Okay.
Including the that's what is that?
So when you are calculating intake-output chart in ICU, that is entirely different from ER. ER, you are only giving fluids. Okay. But in ICU, you are giving a lot of other things. You are giving various drugs. These drugs should be diluted in some amount of water. So you have to calculate everything. When you are calculating intake-output chart, normally you will have difficulty in ICU because we are giving drugs, we are giving fluids, oral feeds are there. So many a times intake-output chart may not tally. So we have to be very careful.
We also have to take into consideration the insensible losses also.
Okay.
And plus this patient was in hyperglycemia.
In ICU,
So,
what is insensible
dehydration.
loss?
Basically, when you respire, sweating.
Near ICU.
ICU.
Even the fast breathing can actually.
Humidity.
Near ICU, it is 500
Plus 500
ml per day in a normal person. But if somebody is having high degree fever, somebody is having rapid breathing, then the fluid loss can increase. So 500 to 700 is insensible loss even in ICU. Okay, ward it may be slightly higher. Okay.
Then the other problem that she was facing was that she was anemic. Hemoglobin was 7.34, but she also had iron deficiency in her blood. We started her on iron correction, but since she was also a known case of CAD, the target hemoglobin was 10 gram per deciliter. So we had to transfuse her with 1 pint of PRBC.
So normally blood bank teaching is never give 1 pint. If you are planning to transfuse any patient, correct it. So now you have 7 hemoglobin. Suppose you want to correct because of some problem, you correct it. Correct it giving by 1 or 2 because each pint will increase only by 1%. Okay. So correct. Anyway, you are taking a risk. Any blood transfusion is a risky thing for the patient because blood transfusion has got its own demerits. What are the problems it can produce?
Bloodborne infections, trally.
Okay, most important is trally
overload.
because bloodborne infection nowadays it is very rare. But trally is very important problem. But mostly it is for plasma and other things. But even here it can produce volume overload.
Hemodilution.
So anyway, you are taking a risk. You transfuse and correct it. Okay, make it about 10. Because in acute coronary syndrome or whatever it is, you have to keep the HP a little above the normal. That is about 10. Okay, so we try to give more transfusion. Meanwhile, you can even correct the iron also.
So then we dealt with each problem. So now in due course of time, she's actually improving.
Okay.
Probably another 2-3 days,
we can discharge her. Sugar?
Sugar levels came down. So then we calculated the whole 24 hours of her requirement. Then we divided as basal and bolus doses and we fixed her insulin levels.
Okay.
So now she'll be off the OHs and now her insulin levels will be, regimen will be given like that.
Okay.
So yeah, that's about it.
Anything you want to correct?
Glucocorticoids actually. It's not routinely recommended in case of aromatic pneumonia, but if the patient is having a background of COPD or it's in a case of refractory septic shock, we can actually consider giving. So it can actually counteract the inflammatory response to the pneumonia. It's not recommended for all patients. Second thing, if you're starting an empirical therapy, antibiotic therapy, within 72 hours, if it's not improving, we have to think about starting or shifting to a higher variant. And also, similar to that, de-escalation should also be thought about once the patient starts improving.
Okay.
So one thing will be clinical improvement. Second will be like drop in lab parameters like drop in inflammatory markers, procal, everything will be dropping. And also the repeat cultures will be showing negative.
Okay.
So in these conditions, we can think about de-escalating the antibiotic. So yeah. And also in these patients, nutrition is also very important. So we have to like maintain about 30 to 40 gram calorie per kg should be adequately given so that because the patient having initially respiratory distress will be using more excess amount of energy and compared to a normal person.
Okay.
So these things can be like titled in the ICU for further.
Okay.
And also a patient with a known case or a diagnosed previous hospital showing a pseudomonas infection, we can start on initial arrival itself. We can start on an anti-pseudomonas this combination of either piperacillin tazobactam or an carbapenem plus a respiratory fluoroquinolone with an anti-pseudomonal activity.
Okay.
That's the third option for empirical treatment in a case who is a diagnosed previous reported pseudomonas.
Okay.
Thank you.
Thank you.